Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody's doing great. Let's start our new lecture, which is about seizure. Yeah. Okay, let me put it in slideshow here. Here we go. All right. Okay. Seizure. Definitely, it's going to be one of the, not one of the, it is a very commonly tested topic. So definitely you get question out of maybe between 1 to 5 question from the seizure. So very commonly tested. It's very hard to say if you're getting question from the clues, symptoms, or the treatment, but you will definitely get question out of these topics that we are discussing today. So what should you be able to get from this lecture? Recognize epilepsy from a seizure, classify the focal, generalized, unknown, unclassified categories, how to do the investigation for somebody who has seizure, like the glucose, the lab, EEG, MRI, CT, LP, and toxicology appropriately, how to treat, and what are the specific medication used for a specific seizure. And avoid the traps, obviously, because they're going to set some traps for you and they expect you to fall in that trap. But I will prepare you to avoid those traps. A seizure is an event. Epilepsy is an enduring disorder. So it means seizure is just like an attack, like an incident, like an event, but epilepsy is enduring disorder. It's a disorder. Not every seizure is an epilepsy. So seizure is a transit or transient episode from abnormal excessive neuronal activity. Maybe acute symptomatic metabolic, maybe it is acute symptomatic, for example, metabolic, toxic, infectious, structure, or withdrawal related. For example, seizure could be due to metabolic disorder. Maybe it happens due to any toxic exposure. Maybe it happens as a consequences of infection, untreated infection, or any structure abnormality, or from withdrawal cases. For example, let's say you have a patient which usually, just remember this, I might not have it in the cases, but I forgot to put it here. Just remember it, it just came to my mind. They may test you on seizures secondary to withdrawal of medication like benzodiazepine. Someone who has been taking benzodiazepine for any reason for a long period of time, suddenly the patient has stopped taking the benzodiazepine, develops seizure. So that could be from withdrawal of the medication. Okay. Treat the causes. One provoked seizure does not automatically means it is epilepsy. Okay. So seizure is an incident. Epilepsy is enduring disorder. It means if you have 2 unprovoked seizures for more than 24 hours apart, this could be an epilepsy. 2 unprovoked seizures. Seizure happened, there is no provocation. There's no reason for it. You have no idea what happened. And it happened twice, 24 hours apart. It could be an epilepsy. Or 1 unprovoked seizure with 60 or more than 60% 10 years recurrence risk. 1 seizure with high risk of EEG, MRI, brain lesion. For example, the patient has developed seizure. 1 seizure is not 1 epilepsy, right? It has to be at least 2 unprovoked seizure 24 hours apart, so that we can say that this might be epilepsy. But what if the patient has one seizure? If the patient has one seizure and you do some investigation, and those investigations shows that there is a high chance of recurrent seizure, more than 60% in this patient, this is also considered as an epilepsy. Now, the first decision is whether the patient is still seizing. So usually, if it is not seizure, it should be less than 5 minutes. But if it is active, it means the patient is still seizing more than 5 minutes. Stop, not baseline. Usually, it could be due to another causes. For example, check the glucose, the oxygen, and stuff like that. Back to baseline, reconstruct the event, identify the triggers and risk stratification for the first seizure. Basically, the ILA 2025 divides the seizure into 4 different parts. The first one is the focal, begins in one hemisphere. It begins in one hemisphere. Generalized engages both hemisphere from onset. So focal can start from one hemisphere, can go to the other hemisphere, and it can be generalized. But the generalized starts from both at the same time. So the onset is from both hemisphere or from all over the brain. And so the onset will be from the whole brain. The focal will start from the focal area. Unknown, insufficient evidence, I think it's self-explanatory. Unclassified is confirmed seizure with but insufficient description. Focal seizure are localized by the story. Unconscious preserved, conscious preserved, conscious impaired. So patient recalled the event and response appropriately. Motor unilateral colic activity, clonic, and tonic posture, head-eye version. So in terms of motor, it could be unilateral clonic activity, tonic posturing, or head, or it could be just eye version of it. The sensory could be tingling, flashing lights, unusual smell, or taste. Autonomic epigastric rising, paler, sweating, piloerection. Like, I don't know what you guys calling it. Piloerection when the hair stands. Conscious
Goosebumps.
Goosebumps, thank you. Reduce awareness or responsiveness at any point. Behavior arrest or blank stares. Automatism. Automatism is lip smacking, chewing, flambing, picking. Postical confusion supports an epileptic event. Now, generalized seizure have distinct exam fingerprints. For the type, we have absent, tonic-clonic, myoclonic, atonic, and tonic. So these are the types. So what is absent? Absent means brief staring. Usually for seconds, the patient stops suddenly, like everything frozen for him. And for you too, the one who is witnessing the patient, he just stops blinking for a few seconds, an abrupt recovery, maybe for a few seconds, 30 seconds to 1 minute, or usually it's less than a minute, but for a few seconds, abruptly recovering, not postical confusion. So it means the patient does not look confused after recovery, as opposed to tonic-clonic, which the patient will have postical confusion. And something that the MCC love to test on absence is the spike wave. When you do the EEG, the 3 hertz spike wave will be positive. So please remember this. They love to test you on this one, okay? So the absence, the patient is physically there, but the soul is leaving the body. So he is absent and everything is frozen just for a few seconds, and he comes back and he doesn't remember what happened. So There's an abrupt recovery, but no confusion whatsoever. The tonic-clonic is stiffening, rhythmic jerking. Tonic-clonic, okay? Tonic-clonic, postural confusion, fatigue, and for this one, the most common thing or the most picked finding that they want you to know in the licensing exam, or they usually pick it from the scenario and want you to know as an option that is very commonly seen in tonic-clonic, is the lateral tongue injury. Okay. Myoclonic. Myoclonic is a brief shock-like jerks, morning jerks, dropping object, considered juvenile myoclonic epilepsy. Atonic is sudden loss of tone. So atone. Tone is the stiffness. Atone when you lose the tone. So suddenly the patient drops, doesn't sleep. The patient has seized, but the patient doesn't have tone. For example, you're talking to somebody, suddenly the patient just drops out. Like he just fall down. And he is not seizing. He doesn't have the tone to stand up. Completely drop attack. Tonic is the opposite of that. The whole body stiffens, often during sleep, and atonic usually happens when the patient is awake, but tonic is happening when the patient is sleeping. Consider generalized syndrome. Now, in terms of the area, the aura often tells you where the seizure began in terms of location of the seizure that originates from. If it is temporal, remember, if it is temporal, usually the patient will have fear. The patient will explain something like deja vu, or the patient may usually out of these three, I have seen all three, but out of these three, deja vu, rising epigastric sensation are very commonly mentioned in the scenario. Okay, so these three is very common: olfactory, gustatory, or aura, and automatism. They're all going to be present, but in all cases, they cannot include all these findings. So usually the very commonly used clues are going to be the fear, deja vu, rising epigastric sensation. If you see this, think about temporal lobe. Okay? So, for example, they give you a scenario about somebody that who explained that he, before the seizure happens, he starts feeling scared and he feels deja vu or rising epigastric sensation, or he feels or he smells things that he cannot explain, or gustatory aura, like, you know, sometimes you feel like nauseated, automatism, smacking lips, something like that. And then the seizure happens. He knows that it's coming. This is temporal. If it is asking you which area is affected or which lobe is affected, temporal. Frontal, brief, frequent. For the frontal, usually they give you a scenario about someone that who is having seizing and very bizarre movement during sleeping, nocturnal, hyperkinetic, or bizarre motor activity. Like he's punching, doing this and that, like he's dancing. It's a bizarre movement, but he is sleeping, and it happens during night. And rapid recovery. Parietal contralateral tingling or sensory march, altered body sensation. Occipital, brief positive visual phenomena. So occipit is the area for the vision, right? If the patient says that he is seeing color, that he cannot explain it, or he has never seen it before, or visual distortion, or flashes, or he sees things that he cannot explain it to you, those are coming from the occipital area. Trap. The frontal lobe seizure may look psychogenic because movement can be dramatic or stereotype, and sleep onset are clues, usually during the sleep. Context separates seizure, syncope, and functional event. So epileptic, stereotype, lateral tank, remember this is how we differentiate epilepsy from syncope or epilepsy from a functional event. Postical confusion and thought paralysis or thought weakness. For example, for thought weakness, the patient after seizure is complete like a hemiparesis. One side of the body is paralyzed, but slowly between 3 to 36 hours, the patient gets back to normal completely. So these are the things that differentiate the epilepsy from syncope and functional event. Syncope is upright trigger, warm, pallor, sweats, brief loss of consciousness, rapid recovery. For the syncope, it's a brief loss of consciousness. The patient feel warmed, pallor, sweaty, and lose the consciousness and comes back. Within a second, the patient is back in the game, or he's back here. Rapid recovery. And functional variable or prolonged movement plus eye closure, fluctuation course, video EEG confirms it. Use respectful language, functional seizure, or psychogenic non-epileptic seizure. The event are real and treatable. The witness history often makes the diagnosis. So something that we need to keep in mind that it might be an MCQ1 question, and also it will definitely be part of the NACOSKI station as well. So in MCQ1, if they ask you what is the most reliable or who is giving you the most reliable history, it will be the witness. Okay, the answer will be the witness. The witness will give you the most reliable history because the patient is seizing. The patient was out of conscious, so he cannot give you the most reliable history. So the witness or the family member would be giving you the most reliable history. But in the history, it is not only, or it is not like a routine history that you're taking from the patient. It has to be the part that you need to cover before seizure, during seizure, post seizure. And also medication is part of the history, right? So before the seizure happened, what triggered it? What are the triggers? Was there any sleep deprivation? Was there any illness? Was it a medication missed or non-compliance to medication or treatment? Was it any substance abuse involved? Or was there any aura? During the season, now here we need a witness who can give you most reliable history, because the patient now, he might be able to give you before, he might be able to give you after, but during seizure, he cannot give you a history. That's why it's not most reliable. But if the patient gives you the before and after, and somebody who witnessed it give you the during, this is going to be a very good and detailed history. So the eyes were open or closed, head turn, asymmetry, color change, duration, responsiveness, if the patient lost the bladder control, bowel control, if the patient was, if the duration was less than 5 hours, less than 5 minutes or more than 5 minutes, all this has to be documented, and they make a huge difference. After confusion, after the attack, was there any confusion, focal weakness, aphasia, fatigue, rapid recovery, or injury? Background, prior episode, birth, prenatal history, head injury, stroke, infection, trauma, family history. These are the things that has to be collected as a part of the history taking for seizure. Now, medication, if you notice, this is a different color, and I made it different because these are the medication that they will bring down the seizure threshold. If the patient is taking these medication, it means it is very easy to treat it because these are the medication that they are bringing the seizure threshold lower, and the patient is um, uh, developing seizures. So you can stop these medication or switch them to a different type of medication that can do the same thing, except for the touching the seizure threshold. For example, bupropion is one of the antidepressant medication that is bringing the seizure threshold lower, and it causes seizure, right? So we can ask the patient to consult with a specialist to change bupropion to a different antidepressant, tramadol, stimulants, antipsychotic, antibiotic, and also if there is any withdrawal, we take care of that, and also adherence. Is the patient taking the anticonvulsant medication or not? So medication is a major aspect of the history that has to be covered. If you don't cover it, you lose a lot of mark. On sometimes in MCCQ1, they will mention that these medication are, they might indirectly throw it in the scenario. So you should just keep an eye on these medication. If you see it, you know that these are the reason for the seizure. And you need to know how to approach the management based on those medication. Okay, examination finds the cause and the complication. Immediate. So what do we have to do for somebody who is seizing? Obviously, someone that who is seizing is needs for stabilization, right? We have to apply the ABC, ABC, airway, breathing, circulation, vitals, oxygen saturation. Capillary glucose immediately. So this is something that they expect you to know and most commonly tested in seizure. They expect you to know, and please check it because hypoglycemia and hyperglycemia, both of them can cause seizure. So you need to check the capillary glucose immediately. Evidence of trauma, aspiration, persistent focal deficit, um, fever, meningitis, severe headache, pregnancy, postpartum status. This has to be checked. After stabilization, full neurological examination, mental status. Again, lateral tongue injury and postacal weakness supports seizure. Papilledema or focal signs suggest structural disease, papilledema. Scan finding may suggest a neurocutaneous syndrome. Thought paralysis is a transit postacal focal weakness, but a new stroke must be excluded when the diagnosis is uncertain. So thought paralyzed, as I mentioned before, that once the seizure is finished, the patient may have one side or hemiparesis, and this will completely resolve within 3 hours to 36 hours. But if it is raising some flags that you think or you're suspecting a stroke, you can always escalate the investigation to rule out the stroke. So it doesn't have to be like, okay, I know this is thought paralysis and he's gonna get better. No, if you notice that the patient is progressively getting worse and instead of getting better, because every hour that passes, the patient should improve. Every hour the patient is getting worse and worse, and you're suspecting the patient did not have this before, always escalate. First seizure testing is targeted, not a routine shopping list. So it means it is not just a list that you need to memorize it and apply it for every patient. Depending on the patient, depending on the condition, what caused the or provoked the seizure, then based on that, you have to do the investigation. For example, capillaries is something that we do for everybody, electrolytes, CBC, renal, liver, a pregnancy test, if they're pregnant, ECG with the syncope, is possible, ECG when syncope is possible. Toxicology, again, you have to do it if you're, these are selective based on the condition. Medication, always you have to ask, but if you're suspecting, you need to go after it. CK, infection testing, and LP. MRI findings, the epileptogenic lesion, CT finds the emergency. So MRI finds the epileptogenic lesion, but the CT finds the emergency. Urgent non-contrast CT scan. So it means for the patient that who has seizure, we can do MRI and we can do the CT scan. If we think that this is something emergency, we do the CT scan. If we want to do an imaging to find the reason for the epilepsy, then we go with the MRI. Like my patient never had epilepsy. The head trauma happened and then the patient developed epilepsy. Now this is emergency. I don't do MRI, I do CT scan, non-contrast. If my patient is epileptic patient, he never had any chance to do any imaging. Now I would like to do imaging for him with an MRI to see what happened and what is the issue with this epilepsy, what causes this epilepsy. I hope it makes sense. Persistent altered consciousness or focal deficit, head trauma, severe headache, anticoagulation, immunocompromised. Concern for hemorrhage, mass effect, or acute stroke. Used when MRI is not promptly available in the emergency setting. Epilepsy protocol MRI preferred structure study after first unprovoked seizure. We usually do this, prefer the structure study after first unprovoked seizure. If it is not emergency, there's no suspicions of intracranial hemorrhage, there's no suspicions of any mass in the head or acute stroke, then I would do the MRI. But if it is emergency, I know that the accident happened, then the seizure happened, I go after the emergency, which is CT scan. A normal scan does not exclude epilepsy. Even if the scan is normal, it doesn't mean that it's not epilepsy. It is not epilepsy. So I have to dig more. Even with the EEG, negative EEG does not rule out epilepsy. LP follows imaging. LP follows imaging first when the mass effect is a concern. Treat suspected CNS infection without avoidable delay. So a normal EEG does not exclude epilepsy, as I mentioned before. So a normal CT scan does not rule it out, and a normal EEG does not rule it out. The reason we do the CT scan just to make sure if it is not emergency. If it is an intracranial hemorrhage that causes the epilepsy, the seizure, then I have to take care of that intracranial hemorrhage, and the epilepsy will be treated on its own. We don't even have to give them any medication for a long time. What it can show, epileptiform discharge, increased recurrence risk. So for the generalized, 3 spike wave supports typical absence. Just remember this, again, for the absence or for the generalized, in 3 or 4 to 7, usually, they will mention this in the scenario, 3 or 4 to 7. Focal abnormalities help classify and localize this. What it cannot do, a normal routine EEG does not rule out epilepsy. An abnormal EEG alone does not prove the clinical event was a seizure. Repeat sleep deprivation, ambulatory or video EEG may increase yield. So acute symptomatic seizure, correct the triggers. What is the trigger? What is the cause? Is it metabolic? Does the patient have hypoglycemia? Does the patient have hyponatremia, hypocalcemia, renal failure? What is it? Whatever the trigger is, remove it. Toxic or withdrawal. Medication toxicity like bupropion, substance exposure, like for example, cocaine, alcohol withdrawal, benzodiazepine withdrawal. Structural, stroke, hemorrhage, tumor, trauma, vascular malformation, infectious meningitis, encephalitis, and cerebral palsy can cause seizure, systemic fever in children, eclampsia and pregnancy, and severe hypoxemia. Treatment after one seizure depends on the recurrence risk. Higher risk, epileptiform EEG, abnormal brain imaging, or a remote structural lesion, abnormal neurological examination, nocturnal seizure. This is very important. High risk, very high risk. Recognize epilepsy syndrome. Shared decision, immediate treatment, reduce early recurrence. So it means if there is an epilepsy, sometimes they think, oh, it's not going to happen again. It will happen again. And then it happen again, and then happen again. By the time you get to the doctor, it will be to the stage that nobody can help you any longer. So immediate treatment reduces early recurrence. So if it happens, the sooner you seek medical attention, the better it is. It does not necessarily change the long-term remission. Balance recurrence consequences, medication effects, occupation, driving, and patient preference. Two unprovoked seizures usually justify long-term therapy because recurrence risk is very high. Choose medication by seizure type and patient profile. Now, the same thing that we were doing for the migraine prevention, we have list of medication, but they are not like the way that everybody is memorizing it. So it doesn't have to be memorized. Every single one of them is used in a specific condition. For example, for the focal, the best choice is lamotrigine. The second best choice is levetiracetam. So levetiracetam is almost always the best choice, except for the absent. Okay, levetiracetam, if you see it anywhere, is always the best first choice, whether this is focal, general, myoclonic, it is usually the first best choice. Except for the focal, it is the best choice, but they prefer to use lamotrigine or levetiracetam. So, but still, it is the first choice. Generalized, it is the first best choice. The myoclonic, the first best choice. Select use of the valproate for myoclonic. For myoclonic, what they are juvenile myoclonic epilepsy. What is very important to remember is certain medication makes them worse, and also even for the focal. So carbamazepine, all those anticonvulsant medication ending by pene, try not to use it very frequently or routinely because their side effect is hyponatremia, and hyponatremia causes seizure. Okay? Any anticonvulsant ending by pene has a very severe side effect of hyponatremia, and hyponatremia causes seizure. So try not to use it unless there is no other choice. Again, let's move on to the focal. If the patient has focal seizure, go with lamotrigine or levetiracetam. Carbamazepine or oxocarbazepine can worsen some generalized epilepsy for obvious reasons that I mentioned. For generalized tonic-clonic, levetiracetam or lamotrigine, valproate in selected patient. Avoid valproate when pregnancy is possible unless a specialist criteria are met. Typical absence or absence seizure, etosuximide. This is the best medication. I forgot to make it red. They also love this to use it as a question, like what is the best choice or best treatment for typical absence seizure? It will be etosuximide. Use valproate if other generalized seizure typical coexist with a reproductive caution. So this is going to be the best choice. Myoclonic, levetiracetam. Select use of the valproate. Again, carbamazepine and phenytoin may worsen the myoclonus. Carbamazepine worsens the general and also the myoclonus. Phenytoin, which is also used for the generalized tonic-clonic, can also worsen the myoclonus. Okay? Unknown type, use broad spectrum agent. Again, levetiracetam will be the best choice. Do not choose a narrow spectrum drug before classification. lamotrigine is why it is always used as a first best choice, because it is mood friendly, broad spectrum. Lamotrigine is mood friendly if someone that whose mood is switching, or you think that this patient is a moody person that's switching between depression and mania very quickly, or he is not diagnosed with it, but still somebody who is very sensitive in terms of mood, then you can use lamotrigine. So levetiracetam has, why it is the first best choice, because it has less interaction. If you have a patient that who is taking multi medication, let's say you have 65 years old who is on 10 different types of medication. So for that patient, the safest medication will be, if he develops epilepsy, will be levetiracetam. Why? Because he's already taking 10 more medication, and out of those 10 medication, 2 or 3 of them will definitely have interaction with the epilepsy medication. But if it is levetiracetam, the chances of an interaction with those 10 medication is much lesser. So if you have, pay attention, these are very, very fine clues. They mention an elderly with a multiple medication. The patient is using multiple medication, or the patient is on polypharmacy and develop epilepsy. Which one do you choose, lamotrigine or levetiracetam? Levetiracetam. Why? The patient is already taking 10 more medication. The chances of interaction is very less. Now you have another patient who is 35 years old with the epilepsy. The patient is a little depressed. Now, in here, even levetiracetam would be a best choice, but lamotrigine plays the best option because the patient has mood problem. Or if the patient is asking you specifically a mood-friendly anticonvulsant medication, then go with the lamotrigine, because the patient is not taking too many medication so that you have to worry about levetiracetam. Still, you can use the levetiracetam unless the patient is asking for a specific medication. Carbamazepine, effective focal agent. It is good for focal, but worsening the general. Like if you have a focal seizure, you can use carbamazepine, but carbamazepine worsens the general tonic-clonic seizure. So again, not only that, it also worsens the myoclonus. If the patient has myoclonus or a shock-like jerky movement, it will be worsened. So in that case, I will probably not pick this as the best choice. Why? Because it has the side effect is the hyponatremia, diplopia, ataxia, rashes. Interaction is very high, HLA risk. Same thing, almost the same thing. Locosamide, useful adjunct treatment, and also as a monotherapy. The side effect is dizziness, PR prolongation. Consider ECG. So before I start using this, I will do the ECG. The reason is that it's prolonging the PR interval. Generalized epilepsy contains the classic medication traps. Mush syndrome, typical absent use etosaximide. Myoclonic seizure or juvenile myoclonus epilepsy, levetiracetam or a specialist selected valproate. So usually the levetiracetam will help a lot. So you don't even have to go to valproate. But if you want to, then that will be very selective. You have to weigh the benefit. If the benefit outweighs the side effect, then yeah. Generalized tonic-clonic seizure, again, broad spectrum. Broad spectrum is the lamotrigine. If they ask you for broad spectrum, go with lamotrigine. If it is asking you for rapid effect, levetiracetam. But for generalized tonic-clonic, both the levetiracetam and lamotrigine is the best choice. It's, again, if they're asking you for the friendly, mood-friendly, lamotrigine. Broad spectrum, lamotrigine. If it's asking you for rapid effect, levetiracetam. Morning myoclonic jerks, levetiracetam. What makes it worse? Carbamazepine. What makes worse generalized? Carbamazepine. What makes worse myoclonus? Phenytoin. Can we use phenytoin for generalized? Yes. Carbamazepine and phenytoin may worse absence or myoclonic seizure. Of course, valproate is very highly teratogenic and requires a strict reproductive safeguard. So if you're using this, you have to ask the patient not only use the condom, the patient has to take the contraceptive as well. Lamotrigine may be less effective for myoclonus and must be tethered slowly. Do not classify every bilateral convulsion as a general. And also for valproate, remember, it causes pancreatitis. The reason I mentioned, because there was a case in one of the subscription that the patient developed pancreatitis who was taking valproate for a long period of time, and the patient had pancreatitis. And what was the reason for the pancreatitis? Was the valproate used for a long period of time. Just remember this and take a note. Valproate causes pancreatitis for a long period. Exam clue: brief morning jerks plus generalized convulsion after sleep deprivation, juvenile myoclonic epilepsy. If it is less than 20 years of age. Anti-seizure adverse effect are tested as a clinical clue. So valproate, weight gain, tremor, hepatotoxicity, thrombocytopenia, and pancreatitis. Please add that as well. Neurotube defect and neurodevelopmental risk, so avoided in pregnancy. Topiramate, cognitive slowing, paresthesia, kidney stone, weight loss is the side effect, which in most cases, people with the epilepsy, if they want to lose weight, they will ask for a medication that is helping with the epilepsy and also helping with the weight gain to lose weight. Phenytoin, ataxia, nystagmosis. Please remember this. I don't know why they love to use the adverse effect of phenytoin, which is ataxia, nystagmosis, gingival overgrowth, and neuropathy. Okay, please remember this. I have seen it in so many subscriptions. I forgot to make it red and bold, but remember, phenytoin, ataxia, nystagmosis, gingival overgrowth, and neuropathy. Non-linear kinetic, IV cardiac risk, long-term bone effect. Carbamazepine, hyponatremia, leukopenia, rash, diplopia. Among all of them, they love to test you on hyponatremia. Okay. Lamotrigine, rash, and SJS, St. John syndrome. Slow titration, valproate raise, lamotrigine level, levetiracetam, irritability, behavioral symptoms, few drug interaction. So pregnancy planning protects patient and fetus. Do not abruptly stop anti-seizure medication. We never do that, right? So let's say your patient is taking the medication, valproate medication, and the patient is somehow didn't consult with you, and now the patient is pregnant. So you cannot say stop the medication and then come back in 2 weeks. We will talk about which medication do we start. No, don't do that. Do not abruptly stop the anti-seizure medication. Plan emergency pregnancy early with a neurology plus obstetrics. Prefer effective monotherapy at the lowest effect dose. Avoid valproate when pregnancy as possible. When the alternative, whenever alternative works, use folic acid before conception. Always, regardless of the seizure, we usually ask the patient to start at least 3 months before pregnancy to start the folic acid and continue until 3 weeks after pregnancy or during pregnancy. And then based on the condition, we decide what to do, increase it, decrease it, or after delivery, should we still continue it? Monitor level when pregnancy alters clearance lamotrigine. So just to make it very simple, if the patient during pregnancy is taking valproate, switch it to lamotrigine. Or if the patient wants to get pregnant, change it to lamotrigine before the patient starts to get pregnant. 5 minutes of convulsion is the status epilepticus, treat now. Continuous seizure, 5 or more than 5 minutes, or recurrent seizure without recovery, convulsive, status epilepticus. So for the first 0 to 5 minutes, stabilize plus glucose. If it is 5 to 20 minutes, then I will start giving the patient benzodiazepine, right? So let's say the patient is seizing 0 to 5. What do? Stabilize the patient and check for the glucose. Now you see that the patient is still seizing and it is 6 minutes. So between 5 to 20 minutes, I start benzodiazepine. Now it is 20 to 40 minutes. Still the patient is seizing. Second line loading. Now if it is refractory, ICU plus continuous EEG. 0 to 5, protect the area position, oxygen, capillary, if hypoglycemia, give dextrose, timing when the deficiency risk, draw targeted lab, but do not delay the anti-seizure medication. 5 to 20, so obviously we have to start with lorazepam, which is the best benzodiazepine, 0.1 milligram per kg, maximum is 4 milligram, may repeat once. If the patient is, if you cannot find the vein, so there's no IV access, then you need to do an IM. IM midazolam is preferred, even though you have intranasal, buccal midazolam, but the IM is preferred if you cannot access the vein. Alternative IV, again, diazepam is an option, but if you can't, then this would be a question that you have a patient and your patient is seizing and the patient is seizing for 6 minutes now. You're trying to give her IV lorazepam, 0.1 milligram per kg, but you fail to find the vein. What is the next best step? What is the best next step if I cannot find the vein or I cannot open an IV? I give him IM midazolam. Common failure, underdosing the benzodiazepine because of the fear of respiratory depression. So this is something that the people are afraid of, that if I give my patient too much benzodiazepine, the patient will develop respiratory depression. So what we can do, this is a common mistake. So stick with the rule, stick with the criteria. It is lorazepam 0.5 milligram, okay? Now 20 to 40, load 1 second line anti-seizure medication. So option, levetiracetam, okay? 6 milligram, again, they're not gonna ask you about the dosage. You don't have to worry about this. Phenytoin, valproate, phenobarbital. So they're the typical loading anti-seizure if the benzodiazepine doesn't work. The levetiracetam has fewer interaction. There's avoid, monitor, and conduction. Valproate, avoid pregnancy. Phenobarbital, more sedation and respiratory depression. Levetiracetam, phosphophenytoin, and valproate have broadly similar efficacy. Comorbidities often decides. Persistent coma may be non-convulsive status. Refractory convulsive status and non-convulsive status. Ongoing seizure despite benzodiazepine plus second-line medication. ICU, airway control, anesthetic infusion per protocol, continued EEG guide, seizure suppression. Non-convulsive status, persistent unexplained impaired consciousness, subtle eyelid, facial twitching, gaze deviation, automatism, or no obvious movement. Urgent EEG confirms ongoing electrographic seizure activity. Exam triggers: not waking as expected after generalized conversion. Check glucose image as indicated and obtain EEG. Usually the patient should come back to consciousness, but if it doesn't, it means two things going on. One, the patient is still seizing, or there is something else causing the seizure to get worse, and you need to find it. Whether it is intracranial bleeding, or if it is an OPSE, or whatever it is, you need to find it. First aid prevents secondary harm while the seizure stops. Do protect from nearby hazards. So these are the things that if you're doing your NACOSCI, you need to have them as part of your consultation. What to do, what not to do, protect from nearby hazards, caution the hate and the loose and restrictive clothing, time the seizure after jerking stops, place on the side of breathing, call emergency, place on the side of breathing. The patient is breathing, so put them on the coma position, right? Lateral position. Call emergency service for 5 or more than 5 minutes of seizure, repeated seizure, injury, pregnancy, water event, and first seizure. Do not restrain movement. Like if he is seizing, do not hold him or refrain him. Let him do it, but make sure that he is not hitting something that is pointy to break his hand or cause any wound or injury. Do not place anything in the patient's mouth, which traditionally some countries, including our country, they used to do their shoes. They were putting it in their mouth and nose. Do not give food, drink, or oral medication until fully conscious or alert. Do not assume every event is epilepsy. Do not leave the patient alone until safely recovered. Now, these are another part of the counseling part that's essential for every IMGs to know and cover it in consultation station. For example, driving. These are the things that the examiner expect you to know and mention it. In MCCQ1, probably they may ask you, okay, what are you going to do before you ask the patient to leave the hospital? So I will address the driving. I would address the safety of my patient before I discharge my patient. But in MCCQ1, in NACOSCI, these are the things that you have to cover while you're doing the consultation. And the examiner in the station, he will just take mark. He covered the driving, he covered the water, he covered the machinery, he covered the triggers, and also this and that. So you need to specify it and verbalize it that I'm covering this and this and that. For example, stop driving and follow prevention reporting. Reinstatement rules. Ontario has mandatory professional reporting for the specific high-risk condition. For example, if somebody who is seizing or who has epilepsy cannot drive. So you consult the patient, advise the patient not to drive, and also you have to report to the Ministry of Transportation. Water. Shower rather than bath alone. Never swim alone. Use life jacket for boating. So these are the things that you need to cover and mention to the patient. And when you mention it, the examiner will know that you have already covered the water part. Height and machinery. Avoid ladders, unprotected heights, open flames, and dangerous machinery under controlled. Triggers. Prioritize sleep, adherence, moderation, avoidance of the individual triggers. SUDIP discuss risk when appropriate, especially uncontrolled tonic-clonic seizure, and emphasize seizure control adherence. Now we are doing a few cases. An 8-year-old has dozens of daily episodes of abrupt staring lasting 7 seconds. She stops speaking, blinks, and immediately resumes her activity without confusion. Neurological examination is normal. What is the most likely diagnosis and best initial medication? The best, the patient is absent, right? Staring, lasting 7 seconds. And the patient is not speaking, not and also blinks. So answer, typical absent seizure. What is the best medication? Etosuximide. If absent is the only seizure type. Why not focal, too brief and frequent, no aura, automatism, or postical confusion? EEG clue generalized. This is something that you have to memorize. EEG will show 3 hertz spike and wave discharge. Now, case number 2, first seizure with the focal clues. A 57-year-old experienced a rising epigastric sensation. Then lip smacking and unresponsiveness for 90 seconds. He is confused for 15 minutes. Examination is normal after recovery. What is the seizure type? So 57, epigastric sensation and automatism, right? Lip smacking and unresponsiveness. So automatism. What is the seizure type and which investigation are most important? Classify focal impaired conscious seizure, temporal lobe. Temporal lobe, fear, deja vu, rising epigastric sensation, and automatism. So temporal lobe. Here they didn't mention the fear, they didn't mention the deja vu, but they mentioned the epigastric sensation and lip smacking, which is the automatism. What are the investigation I do? Capillary glucose, target labs, EEG, epilepsy protocol MRI, because it is the first episode of the epilepsy. So I have to do the MRI and urgent CT if red flags are positive. Since the patient doesn't have any red flag, I will skip the CT scan, but I do the MRI and EEG. Persistent convulsion, treat first. Persistent convulsion. A 34-year-old with epilepsy has generalized convulsion activity for 7 minutes, so more than 5. Oxygen saturation is falling. IV access is not yet available. And capillary glucose is normal. What is the next best step? So if the patient is seizing more than 5 minutes, my patient needs an IV benzodiazepine 0.1 milligram per kg, maximum of 4 milligram, right? So IV, but IV is not accessible. Now the next step is to give him IM, and IM midazolam promptly while supporting the airway and monitoring. Trap, do not wait for the IV, laboratory results, CT, EEG before the first line treatment. So I don't have to wait because the patient is seizing. I have to come up with the medication to get rid of the seizure. So provoke seizure, epilepsy, correct the cause, a normal routine ECG does not exclude the epilepsy. CT finds the emergency. Epilepsy protocol MRI finds the subtle lesion, focal aura, plus automatism, confusion, plus focal temporal pattern, brief staring, plus immediate recovery as typical absence, etosuximide, convulsion, more than 5 minutes, status, benzodiazepine now. IV, do not put anything in the mouth or restrain the patient. Avoid narrow spectrum drugs when generalized epilepsy is possible. For the generalized, always use the lamotrigine, broad spectrum, or levetiracetam with a rapid effect. Avoid valproate when pregnancy, driving rules, or provincial consult and report. Recognize, then classify, then identify the cause, investigate selectively based on patient to patient, case to case. It will be different. Treat the emergency, prevent the recurrence and harm. And that's the end of it. Thank you very much. Let's stop it.